he's still giving live. Oh, never mind.
Yes, sir. Yes, sir.
Okay.
So, IOs in the conscious patient. There are times that this is going to be what you need to do. Teleflex has this recommendation, and your medical protocols are exactly this. What we want to do after we start our IO is we want to dose our patient with some local. We're looking for 2% preservative and epinephrine-free lidocaine. Do you guys know where you guys keep that? Anybody know where they have that? It's your cardiac lidocaine. John, you have one of them, don't you?
Yeah, I do.
Thought you did. It's your cardiac lidocaine, pink box, right? 100 milligrams in 10 mLs, 5 mLs. I'm sorry. It's your cardiac lidocaine, right? You guys all use this. So 100 milligrams in 5 mLs, and your loading dose for an adult patient is going to be 40 milligrams of lidocaine. The reason this is very, very important is because every single cc of something you give them that they don't need right then and there is going to hurt. So we need to do this very, very calculated, very, very right. Your lure locks that come with your IO sets, they hold 1 cc. This is important because that's 20 milligrams. So we're going to have this primed and ready to go before we start our IO. And then we're going to follow it with another 20 milligrams of lidocaine. And then we're going to follow that with enough flush to get it all into their bone marrow. So now they've had 40 milligrams of lidocaine, and we're going to let it sit there for a whole minute. When we push this lidocaine, the faster you push it, the more painful it is. So 40 milligrams over 2 minutes. That is a ridiculously slow IV push. I understand that we all don't do slow IV pushes like we're supposed to do slow IV pushes. However, if you don't do this, a slow IV push, it's going to hurt, and they're going to know it, and you're going to know it. So, do no harm. This is very, very important. 40 milligrams slow IV push, and then let it dwell in the medullary space for a minute. Then, follow it up with a hard flush to displace all of it, and now you should be ready to accept your fluids. If you start doing this, and 5 minutes later, they're starting to experience some pain, you can cut this whole dose in half and re-administer it at 20 milligrams, let it sit for a minute, and then hard flush. Okay? Anybody have any questions on that? These are your medical protocols, by the way. This is what you guys should be doing. On a conscious patient, an IO is a very, very feasible option. Even if you don't push fluids, starting an IO because you think that this is about to get bad, it's not going to hurt them. It's a new way to look at starting IOs. This is not a surgical procedure. It can be done when you think you need it. Access and care, it's just like an IV. We watch out for them, we secure them in place, we watch for infiltration, we watch for swelling around the site. The only important thing about this is IOs are designed to be left in. In the United States, they're allowed to be left in for 24 hours. In the UK, it's like 48 hours. But in the US, 24 hours, and then it needs to be removed, and you can put one in the other arm. But since we know it has a 48-hour turnaround time, we can go right back. Other than that, you guys probably won't be pulling these out in the field, but if you were, very simple. Use a syringe. All these hubs are threaded, just like your IV needles are, so you can thread a syringe on, use steady pressure, back, keep twisting a little bit to the right, because if you go to the left, you're going to unthread it, right? And straight out. And you guys are able to remove these in the field. Again, like we don't remove airways in the field. You guys can remove these in the field, although I don't really know what scenario that would be. Any questions so far while this video is playing? Anybody?
What I hear more of when I'm out doing education on this, it's not that you guys are removing them, it's for that instance when somebody that you're delivering this to, they don't know what they're doing. So it's nice for you all to know, hey, come help me with this. I've got a question for you. So that's really why we go over this for you all.
I do not know the amount of drugs in this guy's system, if any. But if there isn't any, which I'm assuming there isn't, this seems to be a very, very simple and painless problem. Driver considerations real quick. These drivers, I know you guys all have them, and I know that you guys everyone likes to pull the trigger on them. Only things I'll say about pulling the trigger on them, it does waste battery. There is an indicator light on the back that you guys don't probably see very often. It's a green light. That light, every time you pull the trigger, is going to flash green. Eventually it's going to flash red. When it does, your driver's got 10% battery life or less. That needs to be replaced. It will still get that I/O, but it needs to be replaced. These batteries are not replaceable or rechargeable, so the whole unit gets replaced. They're also not waterproof, so don't submerge them, but just wipe them down with your cabbie wipes and all the stuff that you guys would usually use to clean your gear. What else is there? You guys probably have these kits as well, the yellow bags. You guys have those in your trucks?
And John, the indicator light, the test light, LED. You went over? Okay.
Yeah.
Sorry.
IO access mechanical CPR devices. We talked about this. These are totally acceptable with all forms of mechanical CPR devices right now. And here's some resources. We can give you guys information if you guys want to get online or look anything up. All the PowerPoints and stuff are all online. That being said, does anyone have any questions? No? Nobody? Okay. If you guys want, we can come over here. I'd like you guys to come over here, see some of these bone blocks.